I'm delighted to next introduce Dr. Margaret Lanca. She's the Director of Neuropsychology and Cognitive Wellness and Director of Population Behavioral Health at Cambridge Health Alliance. She's also Assistant Professor of Psychology and Psychiatry at Harvard Medical School. In the Division of Population Behavioral Health, she oversees the implementation of measurement-based care in psychiatry, develops new programs geared towards precision medicine, improvement of patient-centered care through early identification and intervention of emergent behavioral health conditions. In neuropsychology, she directs a neuropsychology service and oversees the training of neuropsychology postdoctoral fellows. And if that's not busy enough, she also has clinical work, specialized in provision of multicultural neuropsychological assessments, understanding the factors influencing the assessment of patients of diverse backgrounds with psychotic disorders. She frequently teaches on working clinically with patients with diverse backgrounds and using interpreters effectively in the clinical space. Her research focused on improving neuropsychology assessments through investigation of clinical outcomes, stakeholder reviews of neuropsychological report writing, neurocognition, and schizophrenia. And most recently, she's also worked on screening in primary care cognitive stabilization intervention during COVID-19 and developed guidelines for the provision of teleneuropsychology during COVID-19. So it's great to have her with us. She's going to be presenting on working with medical interpreters, shifting from standards of practice to intersubjectivity in the clinical space. Thank you, Maggie. Please go ahead.
Thank you, Dost. Can everyone hear me? Am I off mute effectively? Okay, great. Thank you. Thanks so much. And thank you for having me. Kelsey, would you be able to put up the slides? Okay, so as Kelsey does that, I also want to welcome our two ASL interpreters, Mary Sue Owens and Suzanne Terry, who have been with us this morning and who will have the auspicious task of interpreting about interpreting. And I have reached out to them and will be commenting on behalf of them at the end of the session. So I want to begin by really just sort of introducing myself in the context of interpretation. Why is a neuropsychologist interested in interpretation? And, you know, this really sort of goes back to my history. I grew up as a daughter of Portuguese immigrants in Montreal, and growing up in Montreal, we learned how to speak English and French. And my dad learned French as a second language. My mom learned English because we lived in an English neighborhood. And my brother went to French school. I went to English school. And so around our dinner table, we always spoke three languages. We, you know, fluently in and out. And it wasn't until I was in grade school and I started having friends over for dinner that I started to realize how weird that was to other people when, you know, you start a sentence in one language and then in another. But for folks who are bilingual, polyglot, that really is part of what we do. I went on to graduate school and did my PhD in cognitive psychology, where my focus was on psycholinguistics. I was always interested in how language got represented in the brain, especially in the bilingual brain. And along the way, I also collaborated with a social psychologist and looking at acculturation and how language impacts that. And it's actually one of my first publications in which we found that language is the greatest predictor of acculturation, which stands today too. And part of what I will talk about inherently in this conversation. Later on, as a neuropsychologist, at Cambridge Health Alliance, I've had the wonderful opportunity to work with interpreters for neuropsych assessment, for psychotherapy. And during my psychology internship, I also volunteered to interpret for a psychiatrist. You know, back then, when there weren't as much access to interpreters, you know, having a student who's bilingual work as an interpreter or get some experience was something that was done. Not anymore today. Thankfully, that was an extremely difficult and challenging experience. And I have to say, it is deep in my sincere admiration and appreciation for the work of interpreters, which we'll talk about today. So all that to preface that. Next slide, please. That I want to begin by sort of painting in broad strokes the landscape of the changing face of America and our collective need really to pay attention to issues of multiculturalism and our increased need for interpretation. So if you had not had the opportunity to work with interpreters yet, I dare say you will, and it is incumbent on all of us as providers to learn how to work with interpreters as effectively as possible. And also to talk a little bit more about, next slide please, about interpretation and the rise of multiculturalism. According to the 2022 census, the foreign-born share of US population is at its highest level since 1910, with approximately 44 million immigrants living in the United States, representing 13.5% of the overall population. The Census Bureau projects that the net international migration will be the main driver of U.S. population growth between 2027 and 2038. Today, immigrants settle all across the country rather than clustering in a handful of cities as they did in the past. And about 45% of foreign-born immigrants ages 5 and older have limited English proficiency, LEP. Roughly half of all immigrants report speaking English less than, quote, very well, thus classifying them in the LEP status. And these demographics have placed new demands on healthcare workers. Delivery of culturally and linguistically competent mental health services, particularly in Spanish, with patients with LEP is one of the biggest challenges facing healthcare providers. There is a critical shortage of bilingual speakers available to meet the demands of services for Spanish-speaking patients alone, let alone all of the other languages that are representative. So mental health providers, we need to do a better job in learning how to integrate culturally informed practice and learning how to work with interpreters. Next slide, please. At Cambridge, where I've been working for 20 years, we are an incredibly diverse, we have an incredibly diverse patient population, not only ethnically, racially, but also linguistically. Over half of our patients speak another language at home other than English. 42% of primary care patients at Cambridge Health Alliance have limited English language proficiency and require services of a professional medical interpreter. And interpreter services are offered in more than 60 languages. So over the past the past 20 years that I've been at Cambridge, I have worked with many interpreters, and we have our in-house interpreters with whom I've worked for years, particularly for patients who speak Spanish, Portuguese, and Haitian Creole. Next slide, please. So what I want to talk about today really has to do with sharing with you some of the professional considerations that go into improving cross-cultural mental health care, how medical interpreters are trained and what their standard of practice is, just by overview, to give you a flavor of really what it entails to go through training and to be a professional medical interpreter. And then we'll focus a little bit on how do interpreters interpret, what goes on while they're interpreting, both cognitively and in the room. And then we'll end with a few tips and tricks for working more effectively with interpreters. Next slide, please. So as a neuropsychologist, we often work with folks who don't speak English, and our National Academy of Neuropsychology has put together a white paper published really a long time ago now, 2009, setting the stage for how to help neuropsychologists, and I imagine other professional organizations have done the same for their professions, in terms of striving to provide more culturally competent care. And it really starts when we think about working with interpreters effectively. It also is incumbent on us and starts with us in terms of our own ability to work culturally, in a culturally informed way with our patients. And the better able that we are, the more that we are better able to do that, the more we are able to work more effectively with interpreters. And that'll become more apparent as we go on. So as professionals, we need to strive to ensure that our patients are receiving linguistically, culturally, and clinically competent care. We won't go into too much in terms of the language of treatment, but clearly there are some guidelines to deciding what is the best language of treatment for the patient for a particular situation. Neuropsychological situation can differ from a medical appointment, which can differ from psychotherapy. There are certain overarching guidelines for making those decisions. We can talk about that later. Also, making sure that you engage interpreters who are qualified, having an understanding of acculturation of patients and how that is present in the room, both in therapy and assessment. And also ensuring that as providers, we are trained in providing culturally informed care. I can't underscore that enough. We cannot have this conversation about interpretation without us ourselves understanding that we need to be culturally informed in the care that we provide. Next slide, please. And so to begin with, why don't we just take a small little reminder about what culture is. There are many definitions of culture, but at its very essence, it really is a belief system and value orientations that influence customs, norms, practice, and social institutions, including psychological processes and language. Culture refers to a set of learned traditions and living styles shared by members of a society and includes different ways of behaving and thinking. A minimal definition of culture could be simply the specific way of living of a human group. And culture represents a particular way to adapt and to survive in this particular context. And let's be mindful of that as we think about the multiple cultures that exist in our society, as well as subcultures as well. And all of that we generally process inherently, but in an interpretation setting, we need to be more sort of mindful and conscious of what is going on in the room. Next slide, please. All right, so how do we prepare to work in a medical appointment when there's a patient and the patient is being provided assistance by an interpreter? Well, we have to have a certain degree of cultural preparation for the particular appointment. It's not just about bringing in the provider who will, quote unquote, translate everything for the provider. It's about understanding the cultural values of the patient, the customs, the normative behaviors as much as possible, understanding the patient's symptoms within the context of their own culture, understanding the patient's acculturate of stress, and understanding the cultural perception of the problem. How is the problem perceived in terms of content, cause, and support for that patient within their cultural context? Next slide. So this leads us, of course, to having training in cultural formulation, and there are many ways to get training. This is certainly not the venue here, but I want to just bring to your awareness the DSM-5 handbook for the cultural formulation interview, which is a really wonderful handbook that provides not only theoretical information about how to be more culturally informed in sessions, but also video guidelines and video excerpts as well. Next slide. In this kind of cultural formulation interview training, what one learns is how to frame, not only how to understand what patients are saying through a cultural lens, but how to frame problems and how to ask better questions. And this is very much translates to the interpreter situation, because the more we as providers are able to frame our questions in a culturally informed way, the less of a heavy lift it is for the interpreters to do that kind of cultural interpretation in their work. So let's just think about the simple question: what brings you here today? Well, if we think about this question, it seems like a no-brainer for us within our American context. We know exactly what that means, but it's not an exactly clear-cut question. It has a lot of layers to it, and it has certainly some cultural assumptions. Much like a question, hey, what's up? Imagine an interpreter interpreting that question. As I see on my screen, Mary Stu doing this right now. I'm curious about how she's doing that. But as you can see, it's not literal. There's a lot of cultural influence to that particular question, and a lot of what we say is emboldened by cultural context. Much like our patients, when they are talking to us, they are also speaking through their own cultural lens, which also needs to get interpreted to us. Next slide, please. So just a brief shout out that there's a lot of training that you can seek to get cultural formulation more familiar. Certainly the MHTTC has put on a series a couple of years ago on cultural formulation interview training. And I imagine there's ones elsewhere. Next slide, please. All right, so how do we get to interpreters and interpretation? First, a couple of myths about interpreters. Anyone with any level of bilingualism is capable of interpreting. Not true. Interpreters go through extensive degree of training and learning not only how to interpret information as effectively as possible, but also standards of care and interpreter ethics as well. Next slide, please. I also want to mention in terms of the other slide that one of the myths was that interpretation is the same as translation. It is not. We generally reserve translation as the written conversion of one language to another, interpretation being more reserved for the oral conversion of one language to another. So that is something to be mindful of, because I hear it being used interchangeably all the time. Interpreters have sophisticated levels of training, and medical interpreters go through rigorous training in order to be certified. There are two major certification boards in the United States, the NCIHC, as well as the IMIA board, that will certify interpreters not only in the process of interpretation, but there are some levels of interpretation that are specific to the language. So CMI, there's Core Chi. The Core Chi will certify you for a particular language, as well as a general certification that happens. Next slide. Medical interpreters also have certain standards of practice. I won't go through all of these, but I just want to make you aware of some of the more important ones that are absolutely, spot on to an everyday interaction with an interpreter. Obviously, the goal of the medical interpreter is to make communication between the patient and the provider as seamless as possible, but that's really not the only thing that they do in the clinical realm. They really work towards establishing a therapeutic connection between patient and provider. And they filter not only linguistic information, but all the, quote, extra linguistic aspects, such as structural, social, and emotional constructs that also need to be communicated as well. Next slide. Interpreters have a code of ethics that I feel is really important for all of us to be aware of, not only because it's, you know, good to understand what their ethics are, but for patients as well. They're sometimes confused by what the role of the interpreter is in the room, and so whereas we have a lot of patients have a very clear understanding that when you go into a medical office with a medical provider, that they will maintain confidentiality. It's not necessarily the case, that they have that same understanding about interpreters. And so I will sometimes be in a position to share some of these ethics with patients so that they feel more comfortable in the setting that interpreters are going to be maintaining confidentiality. For example, that they will not take on an assignment if they have a family or close personal relationship. This is particularly important in small multilinguistic communities. I know at Cambridge Health Alliance, our Haitian community is quite small. Sometimes interpreters and no patients from the community. And so for them to know ahead of time that interpreters have a level of confidentiality, much like medical providers in small communities, small rural communities can know their patients outside of the medical office, they are upheld to ethics in their care. All right, next slide, please. So this kind of brings us to, how do interpreters do what they do? The very complex task of converting information for us in the room. And I love this quote from 19th century writer Gustave Flaubert, who wrote Madame Bovary, who said, "The truth is that the fullness of the soul can sometimes overflow in utter vapidity of language. For none of us can ever express the exact measure of his needs or his thoughts or his sorrows. And human speech is like a cracked kettle on which we tap crude rhythms for bears to dance to, while we long to make music that will melt the stars." I hope you got that, Mary Sue. This is just one example of that so eloquently captures the complexity of linguistic expression, the struggle for all of us really to convey our thoughts, and then ultimately for an interpreter to take that expression and to be able to convert it into another language. It's an awesome endeavor and extraordinarily sophisticated. Lev Vygotsky, a 19th century writer and Russian psychologist who I studied, I became fascinated by. He became famous for his theories on intellectual development over time, over the development of it from child to adult. But he also became quite famous because he argued that language, although it's a native ability, it's but socially constructed. So that to answer the age-old dilemma of what comes first, language or thought, he would argue that, you know, a word is but a microcosm of human consciousness, and that only with development does it come to have self-directive properties. So essentially, we a lot of times have our thoughts that we then convert to our language, which then gets converted by the interpreter. And so the interpreter is not only converting the communication, but also the intention, the thought. The interpreter is looking into the soul of the person. This is not an easy process. Next slide. So how do they do this cognitively? I mean, I could talk about this ad nauseum, but I want to just highlight a few parts of what goes into the process of interpretation. Communication is rarely literal, not one-to-one. So at the best of times, we're only approximating what we intend to say. And many words don't even have literal translation at all. There's a poignant example in Portuguese in which we use the word saudade to express a longing, a missing of somebody. But there is no literal translation for this word. It doesn't get captured in any way by just one word, or maybe even a series of words, I dare say. And every language has that. And so interpreters have to do this almost instantaneous calculation of how to best approximate what the patient is saying. Word choice is influenced by culture. Different words can get expressed differently in different cultures, even within the same language. So there's a word in Portuguese called rapariga, which in Portuguese means girl, but in Brazilian Portuguese means prostitute. So when you have an interpreter who's doing this kind of, in rapid interpretation, they must take into account culture as well as language. Metaphors don't translate well. Interpreters try to match level of vocabulary so that as recipients, we understand at what level or what kind of word usage that patients are taking. But it's taxing on working memory. Long expressions are hard to translate. So I often work in small chunks, knowing that as a neuropsychologist, there's only a certain amount that you can really hear and be able to process in sequence, not simultaneously, which is a different process altogether. Interpretation is really increased by organization of thought. And so this is particularly relevant to some of our patients that we see who might have language and communication disorders. Also patients with serious mental illness who have thought disorder. Understanding from patients what their level of disorganization of thought is a hard thing for interpreters to communicate. So I will often, when working with patients with either aphasia, communication disorders of any sort, or thought disorder psychosis, in which they might be circumstantial, they might have neologisms, they might have pressured speech, their speech output might not make sense. We have to remember that an interpreter will naturally try to organize that information as part of their output. What I want from the interpreter in that particular situation is to let them know that I want to hear exactly what the patient is saying, because I want to be able to understand if they're having some thought disorder, if they're having some word substitutions. So working with interpreters often means letting them know ahead of time what one is expecting. Next slide. Ultimately, interpreters work as cultural brokers for us. They're constantly moving from their own cultural schemas to ours, to the patients as well, in making those conversions. George Lakoff, one of my favorite linguists, wrote a really wonderful book, Women Fire Dangerous Things, to sort of capture how categories and language are represented in the mind. And this is something I'm always aware of in an interpreting situation, not only for what the interpreter has to do, but what I have to do as a provider. So in essence, when we work with patients from a different culture and a different language, we always have to be entertaining specific cultural hypotheses. Is this cultural paranoia, or is this suspiciousness, for example? As we're hearing the information, we have to sift the information through a cultural lens, as well as our own clinical lens as well. Next slide. Then this brings up the other piece, how to work with the presence of a third in an interpretation situation, the triadic relationship. The interpreter is not invisible. The interpreter is present. You're working with the patient and the interpreter simultaneously. You and the interpreter are both looking for the hidden patient. through this language communication that is the only vehicle that or the best vehicle that we have to convey all of this information, but not exclusively. You'll often see the interpreter looking at patients just as you, the provider, are, to understand what emotions they're trying to convey with their words, what their intentions are. And the interpreter works to really manage the flow of the communication between all parties. And Jonathan Bolton wrote this lovely paper as a psychiatrist at Cambridge Health Alliance, talking about the presence of the third, and referred to the provider as being perceived as an outgroup, because the patient and the interpreter share language and most likely culture, but not exclusively. But I would say every party is an outgroup. The provider is an outgroup, but so is the interpreter, as they're coming into this medical situation where the provider is helping the patient, and the patient can feel as an outgroup as well, as because the interpreter and the provider are working in concert too. So there is really this triadic relationship where we really have to be aware of the asymmetries, and making sure that they're balanced at all time, and that we work positively with each other, and as well as possible. Next slide. So there hasn't been enough research looking at interpreters in the clinical setting, but there has been some, and increasingly so, in terms of really understanding the interpreter's role in the clinical setting. And I would say that in this research paper that is both qualitatively and survey-based, C does a lovely job in video interviews of how interpreters are working with patients in the clinical setting to try to understand the factors that are contributing to interpreters. And she titled this paper, "Interpreters as Conduits or Co-Diagnosticians." And that can be the term co-diagnostician can be a fairly uncomfortable term for many interpreters, because they've been sort of trained to be invisible. But they're active participants, and they have this incredible responsibility of communicating what the patient is saying. And so they often work not only in terms of converting the language from one to another, but also communicating patients' intent. And in a lot of ways, they can really work just outside of the interpretation. Sometimes they will step in and clarify for providers. They will clarify for patients. And so you can often see this happening in the room. Sometimes it's a little discomforting for a provider to feel like there's some conversation going on between you and the patient. But in many respects, it's a needed kind of querying that the interpreter is trying to get clarity either on what the patient's saying, or putting into context cultural information on top of the linguistic one. And so it's much needed. Many interpreters, and I always ask interpreters to let me know, what they followed up with, so that especially in a neuropsychological environment, I'm really curious of what the patient did not understand, or what the patient was not able to communicate, and that got the interpreter to ask more questions. And so again, working with interpreters means really having a partnership with them in terms of working together for the best interest of the patient. So to summarize, I know I've said a lot at a good clip here today. I'm not going to provide some overall conclusions, because I'd want to be able to hear from you all what you have on your minds in terms of this topic, but just a couple of tips and tricks in terms of working effectively with interpreters. Just general tips that I see as sort of rookie kinds of of endeavors. Speak to the patient, not to the interpreter. Look at the patient, not to the interpreter. Don't ask the patient by saying to the interpreter, could you ask the patient X, Y, and Z? Just ask the question. This helps sort of facilitate the triadic relationship. Attempt to build rapport and therapeutic alliance with the patient. The interpreter will facilitate that through the interpretation, but ultimately it's up to you to emotionally connect with your patient. And the extent that your interview is framed within a culturally informed interview, the interpreter's job will be facilitated. As I said earlier, shorter questions, shorter responses are easier for the interpreter to be able to interpret. Last slide. And finally, these are some tips that were provided to me from medical interpreters in our department. They're very open to having pre-conference before the patient comes in. Talk to the interpreter. Sometimes it's just like a couple of minutes, but just give them the heads up if you're looking for something in particular. So I will let interpreter know if I have a patient whose communication might not be fully intact, and what to look out for, word substitutions, paraphasias, those kinds of things. If it's patients who are disorganized, patients who might have more pressured speech, give interpreters a heads up so that they know what to look for and they know how to help you. And I also provide occasional in-service training for our interpreters as well, to help them understand how to work more effectively with my neuropsychological patients, but certainly patients. I've known of other colleagues who've done the same thing in terms of working with families, in terms of working with patients with psychosis, where communication and language can be particular. So I'm going to stop there in the interest of time, and I'm happy to take questions. And thank you so much, Mary Sue and Suzanne.
Thanks very much, Maggie. Ken, go ahead with your question, please.
Oh, thanks very much for your talk. And I don't know you at all, but I think I have this intense feeling of saudade. But my question, that's a statement, not a question. The question is kind of a translation question. There's a Navigate manual for families, family clinicians, and I'd like to get it translated into some other languages. I'm wondering what is the least costly way to do that?
Oof, that's a good question. I could explore that for you, but there are copyright specifications on a lot of materials that can unfortunately limit translations. We do have a translation department at our hospital, and I have them translate parts of our reports, but whenever it comes to copyright material like questionnaires and so forth, they're not able to translate that. You'd have to really contact the publisher.
Yeah, Ken, I was going to say this in the chat, but definitely happy to follow up with that through MapNet too, because I know we're working, more directly with the Navigate folks. Great.
Oh, thank you. Yeah, I appreciate that. And so it's really the publisher, not the author, that
yes,
has the copyright, if there is a copyright. Okay. Thanks.
And thank you. I think Vera is next.
Yeah, so I'm very interested in this. I've been thinking about getting a medical interpreter certification through my workplace. And I guess one of my question, I guess it's sort of like a two-part question. In terms of considerations for native speakers when they're getting a medical interpreter certification, is there anything that is different about the process to somebody who is who has learned a second language? Or because I learned English and Spanish at the same time. And the second part of that question, I guess, is how do you decide what is sort of standard and what sort of native dialect is sort of prioritized? Because I do tend to think that there's sort of a focus on proper European Spanish above Latin American Spanish, and which I understand is really difficult to standardize because Latin American Spanish has influences from indigenous and African languages. But I was wondering how that determination was made.
Yeah, I mean, I'm not a certified interpreter, so I can help direct you to information for verification. But I know interpreters that come from all cultures and speak different kinds, different cultural Spanish languages. It's not really based on having one kind of Spanish. And at our hospital, we have interpreters from all kinds of Spanish speaking countries, and so you can become certified in as an interpreter, regardless of what cultural identities attached to the language that you're providing interpretation. The only thing that I would mention is that being aware of how your cultural language is different than another is really helpful. And it's helpful to mention. We'll have patients, for example, from Portugal who don't understand Brazilian Portuguese. And so we will request somebody from Portugal and vice versa. And I imagine this sometimes happens for Spanish speaking patients as well. And so I think it just actually augments and adds robustness to the field of interpretation to have multiple Spanish from different cultures be represented. But I could get you more information.
Thank you. I believe Simon is next.
Yeah, thanks, Dost. So this was a little bit, I was just curious if this might be a little more of like a specific practitioner question, but whether people from different backgrounds report different, like, I don't know if there would be symptoms of psychosis, but whether psychoses are different across cultures, or whether there's any indication of that, or what some discoveries might be in that regard.
I mean, that's a really excellent question. I won't do justice in 2 minutes, but certainly symptoms get expressed within a cultural framework, which is part of why it's really important for us to understand how that culture functions and how symptoms actually get expressed in that particular culture. So I will sometimes, have consultations with folks from that particular culture to understand whether this is a symptom that is, part of a diagnosis, or if this is sort of a normal variant of behavior for that particular culture. And I'll give one example that comes up for me, which is around Haitian and sometimes Brazilian too, with spiritualism and spiritual beliefs. Which can be very normative within a culture. And so trying to really understand what that fine line is between, hearing voices and having spiritual beliefs, and how that sort of can encroach on our understanding of schizotypal personalities, or even more full-fledged psychosis, extremely difficult in some cases. And so I will seek consultation, and as in those kinds of situations. This is such a great question, so hard to answer.
Lots of good questions. In the interest of time, maybe let's take one more question and then we'll turn it over to Margaret for the next presentation. I think it was Raquel who had her hand up next.
Okay, thanks. First, Maggie, I wanted to thank you so much for this extremely helpful and informative presentation. What I was wondering is whether there were any written guidelines we might be able to use for the type of information to obtain before appointments that would be helpful in choosing the appropriate interpreter or preparing the interpreter for the appointment.
Oh, wow. That's such a great question. I always sort of think about it in terms of patient specific, but this is the first time I'm sort of thinking about this as sort of broadly in terms of how do you prepare an interpreter for a particular, for your patients or your setting. I'll have to think about it. I don't have a good answer for that because I've always sort of thought about it this as sort of specific, and also because in some ways, I'm a little spoiled at Cambridge in that our interpreters are very familiar with interpreting in psychiatry versus, OBGYN versus labor and delivery. Those are very different interpreter situations, and they work very differently in those situations. And so I already have interpreters who know how to work in a psychiatric situation. And I mean, it's such a great question. I'll get back to you on that.
Thank you.
Fabulous.
Great. Thank you so much for this great presentation, Dr. Lanca. Thanks for joining us.
Thank you.